This episode of Doc Talk is brought to you by the Kappa Boot Scootin' Ball, featuring the president of the Redneck Yacht Club himself, Craig Morgan. Join us Friday, April 5th for the Knoxville's most talked about fundraiser of the year. The event will be packed with great country music provided by Craig Morgan, line dancing, Western-themed dinner, bottomless beverage, and an exclusive Kappa Boot Scootin' Ball souvenir mug. Additionally, a silent auction valued at more than $40,000. Give the opportunity for those in attendance to bid on some packages, including a Dynasty Spa. For tickets, visit KappaBootScootin.com.
Hi, welcome to Doc Talk. Doc Talk is the podcast put out by the Knoxville Academy of Medicine, where we discuss health issues in plain language. I am Elise Denaney, former president of the Knoxville Academy of Medicine, and so happy that you are joining us today. Today we have Dr. Dewey McWhorter joining us, and he's going to talk about sleep. He is the director of the Tranquility Sleep Center, which is located up on Danaher, up in the Emory area. And it's not just sleep that we're talking about today. I do snore. We're going to talk about sleep apnea. We're going to talk about restless legs. We're going to talk about insomnia and narcolepsy. And Dr. Dewey McWhorter has been doing this for several years and can illuminate us to all the nuances of it. So welcome, Dewey.
Thank you. Thank you for having me.
So happy you can join us.
Thank you.
First of all, can you tell people what narcolepsy means?
Sure. Narcolepsy is a specific disease.
Okay.
I think sometimes people get confused and they think this is a general term for sleepiness. But really, narcolepsy is a very specific disease. It is a disease that is a problem with your body controlling REM sleep. So the normal way that your body controls it isn't working quite right. And so you end up getting tired at times during the day. You also have problems with disruption of sleep at night. So narcolepsy is really a disease that is mostly thought of as a sleepiness disease, which it is, but it's also categorized by some other unusual things, what's called hypnagogic hallucinations, where people will see things in the room or hear things in the room that might not be there as they're falling asleep or as they're waking up. And they frequently have what's called sleep paralysis, where they suddenly can't move when they're trying to go to sleep at night or when they're waking up.
Oh my gosh.
Yeah. And then cataplexy is kind of the most dramatic thing you see with it, which gets, you see it a lot when people have movies. In movies, they try to portray it where you tell them a really funny joke or something like that, and some patients will suddenly start to collapse. And they don't all have that, but a lot of them will have that issue too.
Oh, I'll have to look for that in my funny movies. So what causes narcolepsy?
So narcolepsy has to do with something called hypocretin. You'll also hear it called orexin. And basically it's a neurotransmitter that people who have narcolepsy either don't have enough of or they have almost none of. Okay. And sometimes it's probably just that a small part of their brain doesn't really have enough of it. Okay. And it controls your REM sleep. So if you don't have it, the switch for your body to go into REM sleep keeps kind of turning on and off sort of randomly.
Okay, so I've kind of seen the term REM thrown around in, different lay literature, and it stands for rapid eye movement.
Rapid eye movement sleep, yes. So that's your dream sleep. People have dreams in other parts of sleep, but most of your dreaming is occurring when you are in REM sleep, or rapid eye movement sleep, which refers to the fact that when you're in REM sleep, your eyes are kind of moving quickly around during that time.
So you track that with electrodes, right?
Correct. Your eyes are closed, but they're quickly moving around underneath your eyelids.
Okay, and is that good sleep?
It's an important part of sleep, yeah. So it's, there's several different parts to your sleep. There's the lighter stages of sleep, which we call 1 and 2. There's also deep sleep, which we usually just call 3 now. And then there's REM sleep or dream sleep, and they're all important.
Okay, and so sleep apnea. Mm-hmm. Apnea meaning not breathing.
Meaning not breathing, yes. So sleep apnea is where during the night your body will either completely stop breathing at times, or it will have a decrease or enough of a decrease in the breathing that you either wake up for a few seconds or your oxygen levels drop significantly. It is usually 10 to 15 seconds at a time that this happens. Patients will wake up frequently related to this, or sometimes, like I said, it's just a drop in your oxygen. And that takes a toll on your body over time. And I think people always think it has to do mostly with the oxygen. The oxygen is part of the issue, the fact that your oxygen levels are dropping, but the bigger issue is this kind of just awakening over and over again that your body is experiencing during the night, which is causing your body to put out various different things that will cause inflammation in your system and cause you to have smaller arteries over time in your heart. And when you get smaller arteries in your heart, you have a heart attack. You get smaller arteries in your brain, you have strokes.
I get that. I get that. No, really, I get that because, so classic thing. I'm talking with my girlfriend and she goes, I'll be sleeping and all of a sudden I'll hear my husband sleeping next to me and he's snoring away and all of a sudden, dead silence. And then all of a sudden he'll go, and then he'll wake up.
Right.
Or he'll start breathing again. And she goes, is that sleep apnea? And I went, you better get it checked out.
More than likely that's sleep apnea, yes. And that's the typical sort of thing you'll have coming as a story is a spouse is usually coming in and saying, they're making this awful noise at night, I can't sleep, we got to do something about this. And we test them and they have sleep apnea. And most of the time, if it's enough of a disturbance, enough of a snort or a snore or just long pause like that, that it's actually something that the bed partner is noticing, then more than likely it's bad enough that you need to do something with it.
I think your field is so interesting because, at least for sleep apnea, because you don't necessarily have to snore to have sleep apnea. And you don't necessarily have to have being tired during the daytime to have sleep apnea. And you could have hypertension and it could be caused by sleep apnea and you don't even know it.
Right.
Which is amazing because if we take care of sleep, then you don't need your pills.
Right, and that's one of the interesting things about high blood pressure is there is this correlation between having high blood pressure and having sleep apnea. The part that's kind of mysterious is if you have a patient who you've tried really hard to get control of their high blood pressure, and you've got them on 3 medications now and they still have high blood pressure, that usually means they have sleep apnea, and then you treat the sleep apnea and all of a sudden the medication is actually effective for the blood pressure.
That's brilliant.
Right. Well, it's pretty neat. It's hard to say why that's such an unusual thing that happens with it, but for some reason, those patients who are really hard to treat, it actually seems to be that you've got to treat the sleep apnea or else it's not going to get better.
Okay. So, important sleep or good quality of sleep, I'm sure is defined in different ways for different people, but still it's important to get that because so many other things, just like hypertension, are a byproduct of it. What else can people have that is caused by sleep apnea, but they may not know?
So there's so a lot of this stuff is looking at studies where you're looking back and you're seeing that the patient has sleep apnea and they have other diseases that are commonly found with it.
Okay.
So diabetes is the one that really became clear a couple of years ago. If you have diabetes, you have about a 50% chance of having sleep apnea. So it looks like there might be some causative factor of sleep apnea causing diabetes. But there's another theory out there that it's the other way around. The diabetes is making it so your airway is more collapsible because of the damage it does to nerves, and that's why you get sleep apnea. Nobody's really been able to figure that out for sure, but there's a correlation with that one also. The blood pressure probably is that the sleep apnea is causing the high blood pressure issues there. As far as heart attacks, that's also associated with it. Like I said, it's usually related to your blood vessels getting smaller, at least that's what we think. Strokes, same sort of thing. Heart arrhythmias, it's probably that the association is related to damage you're getting to the pacemakers in your heart related to the sleep apnea over time, either because of drops in the oxygen or maybe the inflammation, but everybody thinks that's probably more related to the drops in oxygen that you're having.
So when you're not breathing at night, you're actually dropping the amount of oxygen in your blood.
You're dropping the amount of oxygen in your blood, yeah, and you're having things like adrenaline goes out. You also have what's called catecholamines that go out, and those things are kind of adding to your body's stress and your level of inflammation in your body.
Yeah, which over the cumulative effect over long term, not so great for you.
Exactly, yeah. It's more of a cumulative worry that over time this is going to make things worse and worse. You're going to be more likely to have these health problems long term.
Have they made any association yet between, sleep apnea and Alzheimer's, Parkinson's?
Yes. So Alzheimer's disease, there is an association there. You do seem to be at increased risk for dementia in general, but especially Alzheimer's disease if you have sleep apnea. Why that is exactly, nobody's figured out yet, but I mean, what I would think is that you're trying to break down those little plaques you get in your brain that build up over time that give you Alzheimer's disease. And if your sleep is disturbed, well, the part of your sleep where you're getting rid of those isn't really happening, and you're not getting rid of, your immune system does a lot of stuff while you're asleep at night. I think people think of this passive time where nothing happens, but your immune system is really doing a lot of things. And that's why we really want to get it treated from the standpoint of making you less likely to have health problems long term, is because we know if you have sleep apnea, you're going to be at increased risk for things like Alzheimer's disease. You're also going to be at increased risk for possibly for other diseases that this is a little more questionable, but cancers and things like that, because again, that's when your body is searching for stuff. Your body is saying, okay, let's find out if there are any germs out there and any abnormal cells. And while you're asleep at night, it does that, tries to find those things. And if you're not having normal sleep, then you're going to be at increased risk for having those issues long term.
Okay, so, sleep is excuse me, linked to so many things. I think just a general annual physical should include a sleep study, but that's just a personal opinion. Of course, not fact or proven by evidence-based medicine. However, having the diagnosis of sleep apnea, because so many different things can cause it, right? Obesity can cause it, and like you said, that relationship with diabetes is not clearly understood yet. It's treatable, right?
Right. It's very treatable, yes.
Okay, so I get my sleep study with Tranquility, and they find out that I have sleep apnea. I know there's a whole different grade, like you can have it on a scale of 1 to 10, right?
Right, yeah. Goes from mild sleep apnea to severe sleep apnea, and severe sleep apnea can be a huge range too. I mean, we have patients who have severe sleep apnea that are like, that's bad, and then you have other ones who go, that's really scary. So it's very...
So how do we treat it?
So typically the way you treat sleep apnea is with what we call CPAP, or continuous positive airway pressure, which involves a mask that goes either under your nose or around your nose, or sometimes goes around your nose and your mouth. There's a tube that goes to a little machine that sits by your bed. That machine's blowing in air, and it's holding the airway open with that air. So basically your airway is a collapsible tube. And so if you push in air, then it's going to hold it open some with that. The other thing that I think people don't realize is that when you're blowing that air in, also your lungs are expanding a little bit more than they normally are expanded. So when they're expanded like that, it makes downward pressure on your upper airway also. So it's also kind of holding your airway open with that downward pressure.
Okay.
So CPAP is kind of the treatment of choice, really, just because it's the most likely thing to work. But there are surgeries that the ear, nose, and throat doctors do. There's oral appliances that some dentists make that kind of pull your bottom jaw forward. Those things have some success. It's not as successful as CPAP usually, but they do have some success. And a lot of times we end up having people go and get those things done to try to treat it if they don't do well with CPAP.
Well, and just for me personally, if I don't have to undergo the knife, I don't mind trying something, an appliance. So Medicare will cover for it.
Medicare is very good at covering for CPAP. You can get some coverage for oral appliances, but you kind of have to find a a dentist who does oral appliances and takes Medicare, which can be a little bit tricky sometimes.
Okay.
And so,
how hard is it to adjust to sleeping with something? I mean, we should give it a fair shot. I mean, I know the first night I sleep with something covering my nose or my mouth, I'm just going to feel like, oh, this is weird.
Yeah, this is very new. I mean, a lot of times people have slept for 60-something years without something on their face, and all of a sudden we're saying, put this thing on your face. So it can be an adjustment period that people go through. There's a variety of different masks out there, so typically we just have to work on finding the right mask. So there's what we call full face masks that go over their nose and their mouth. There's also nasal pillows that just kind of go underneath their nose, and there's nasal masks that go around their nose. So there's a variety of different options out there. So usually we can find something that works for everybody. But yeah, comfort is an issue. Just the fact that you've got something on your face is an issue. Getting used to the straps can be an issue. But those are all things that, what I always tell people is, these things have been around for a long time. If you tell somebody what it is that you're having an issue with, exactly what's bothering you about it, usually we already have some sort of solution for it.
Okay. All right. So I get fit with a machine. So I find out which appliance works best for me, and then is there a difference in how much pressure that the machine has to?
So these machines have a range of pressures anywhere from 4 to 20 centimeters of water pressure. So basically that's a measure of how hard the pressure is or how strong it feels to you. And so yeah, there's when people aren't on very much pressure, they do tend to tolerate better. It's hard sometimes when people are on higher pressures. If they get up to 16 to 20 centimeters of pressure, it's much more common that people have issues with that. And usually what you have to do is you have to put on what's called bilevel PAP, or bilevel positive airway pressure, which involves two pressures, one when you inhale and then a much lower pressure when you exhale. Usually that's a little bit easier for people to tolerate just because it feels a little more like your natural breathing to do that.
Yeah, and sometimes you get just as much clinical benefit with a little pressure. It's better than no pressure.
Yes, and that's sometimes what you have to do is sometimes you have to compromise a little bit on, okay, I want to treat the patient. I would like to treat it as well as we possibly can. But sometimes you have to say, okay, well, they only tolerate this much pressure. We've decreased the number of respiratory events they're having by 75%. So we're going to say that's good enough and just keep them on this pressure setting.
Yeah, quality of life is important.
Oh, yes, it's very important, yeah.
All right, so how do restless legs fit into all of this? Do they go together?
Well, you can have an issue where patients who have sleep apnea are at increased risk for having restless leg syndrome related to that. So restless leg syndrome is where you have this awful feeling in your legs where you just feel like you have to move them over and over again. You move them around and then it goes away for a couple seconds or maybe a minute, but it kind of gradually starts to come back, and then eventually you're like, I've got to move them, and you try to move your legs again. So it has to do with part of your brain where what's called dopamine, a transmitter, kind of seems to suppress this urge. And if you don't have enough dopamine in that part of your brain, then this urge is not suppressed, and you end up having to feel like you have to move them over and over again. It's usually very treatable. It's the medications we have out there work really well for it. It used to be we were usually just using things like ropinirole or what's called pramipexole, which are medications that are also used in Parkinson's disease. Those work fairly well. Gabapentin also works fairly well, so we use that a good bit too now. But those are kind of the main things you usually use to treat it. Sometimes it's just related to iron deficiency. And if it's related to iron deficiency, usually you can put somebody on iron supplements for a while and it'll go away. And
That's fabulous. Yeah. Iron deficiency. That I didn't know.
Yeah, and it has to do with the fact that your brain has to use iron in order to make dopamine. So if your iron levels are low, then you're not making enough dopamine in that part of your brain. So.
Got it. So we have only begun to scratch the surface of all the issues that surround good quality sleep. And I believe good quality sleep is really good for good quality of life during the daytime hours. Hopefully we can get Dr. Dewey McWhorter back here in the hot seat so we can talk more about, we didn't even touch on insomnia. So there's a lot of questions. This is not one size fits all. And I think the really important thing to remember is that you may have sleep apnea, not know it. It may be giving you another disease or maybe causing a disease where if you corrected the sleep apnea, then you might actually find some benefit in managing another area of your life. So I know if I need to reach you, I'm thinking, do I need a referral from my primary care? I know that you're also affiliated with Tenova, and so we can reach you by going on the Tenova website. And if I do come and see you, do I have to reserve the whole day for a sleep study?
Well, no. What will happen initially is you'll come in for an evaluation. So you come in, we'll see you in the clinic, and we'll assess whether or not it sounds like you have sleep apnea or not, or another sleep disorder. If it does sound like you have sleep apnea, then we'll have you come in a different night, and you'll sleep in the sleep lab overnight. Typically what that involves is people will come in, and there's somebody there to greet you. There's a sleep technician. They're going to hook up some things that go on your head. They're to monitor your brain waves. There'll be some things that monitor your eye movements that are little electrical leads that go on the sides there. You're also going to have something that goes under your nose to detect air movement at night. There's going to be some other things that go around your chest and your abdomen to detect your body's effort to breathe. And then there's also going to be something that detects your oxygen levels at night.
And you can sleep with all this on.
And that's what when I first started doing sleep medicine, I was really kind of shocked that people were sleeping while they had all this on. And yeah, it's not going to be the best night of sleep you've ever had, but you are going to sleep. And I think part of it too, though, is the fact that so many of these patients who are coming in who have sleep apnea are so tired. And when they're really tired like that, it doesn't matter. You put all that stuff on, they still fall asleep really quickly. But yeah, it's not going to be the best night of sleep you've ever had in your entire life. But yeah, usually people sleep. Every now and then, maybe once a month, we have somebody come through who it really is so uncomfortable that they just can't sleep with it.
Oh, well, thank you so much. Can you tell us again how to get a hold of you?
Sure. We have a website for Tranquility Sleep Specialists. If you just Google that, you should be able to find it.
Okay.
And on our website, there's a couple of different ways you can contact us. There's a little button that says Contact Us. You click on that. You can email us. There's one of these little sheets where you can just fill out your question and it'll go into us that way.
Nice.
Yeah, and then also you can contact us at the Tenova Sleep Centers where I see patients sometimes as well.
Nice. Web-based questions. Go ahead and fire them at him. So there you have it. We've only scratched the surface on sleep apnea and narcolepsy and restless leg. We haven't even touched on insomnia. And hopefully Dr. Dewey McWhirter will join us again in the future. So thank you for joining us today, and that's a wrap.
This episode of Doc Talk is brought to you by the Kappa Boot Scootin' Ball, featuring the president of the Redneck Yacht Club himself, Craig Morgan. Join us Friday, April 5th for the Knoxville's most talked about fundraiser of the year. The event will be packed with great country music provided by Craig Morgan, line dancing, Western-themed dinner, bottomless beverage, and an exclusive Kappa Boot Scootin' Ball souvenir mug. Additionally, a silent auction valued at more than $40,000. Give the opportunity for those in attendance to bid on some packages, including a Dynasty Spa. For tickets, visit kappabootscootin.com.